Thank you. Thank you all very much for the opportunity to speak with you today. I know many of the people in the room and admire all of the work that has been done here. Let's see. Thank you. I am technologically challenged from this. Great. All right. I'm sorry. So what I use this? This one?
Yeah.
Okay. I too changed my slides, thereby changed the title of my talk, thereby demonstrating that with more age comes more ability to talk about what you want. And instead of talking about all minorities and the impact of informed consent and treatment, I'm going to actually focus on people with limited English proficiency. I'm going to talk very briefly about the growth and characteristics of the LEP population. I want to talk about what people are doing to overcome language barriers in treatment-informed consent, and a little bit about where I think we can move forward. Before I do so, a very important caveat, which is that we are in the wild west of no data. You will see many of studies that are single center studies. There are no national data to inform this, or even multi-centered data. So I will try to do my best to point out where I think there are robust data and where they're not. To make sure we're on the same page, the definitions of limited English proficiency used tend to come from the census. As you may know, the census asks the question, does this person speak a language other than English at home? If they answer yes, it then takes them to how well does this person speak English? Very well, not well, and not at all. 60 million people, 21% of the population, speak a language other than English at home. Of this, the overwhelming majority is Spanish at 62%, Chinese under 5%, and all other languages under 2%. Of these, 42% say they speak English less than very well. And of people who report speaking English not well or not at all, people who really cannot participate in treatment conversations, there is about 23% of that population, or about 14 million people, of which 11 million are Spanish speakers. This is a very large number. I'm going to try to see if I can get this point across by simply saying that the number of Spanish speakers in the United States is larger now than the combined populations of Guatemala, Honduras, Nicaragua, and El Salvador put together. If the United States were a country, it would be the third largest Spanish-speaking country in the world. This is an enormous number of people. People are distributed not only in the traditional states, but also in the Deep South. And one way to look at it is using these really nice slides put out by the CDC using census data. The year here is 1980. The deep purple represents areas where the Hispanic population accounts for 25% of the county population. At this point, Latinos constitute 6.4% of the US population. Watch what happens as we advance in time. 1990, 9%. 2000, 12%. 2006, 14.8%. And here the CDC changes its color. The deep purple now represents counties that are more than 50% Latino. US percent is 16.3, and we are at 2010. Currently, there's more than 17% of the population is Hispanic. A quarter do not speak English. LEP patients, however, have many vulnerabilities in the informed consent process. They are less educated. The census tells us that 60% have less in high school. What does that mean? In our own studies at San Francisco General, the mean is third grade education for patients with diabetes. They are poorer, and they, of course, less acculturated to US health practices, including informed consent practices, and often including less questioning of physicians. So what to do? Here we have a New Yorker cartoon. Sounds like dancer, prancer, cancer. Oh, I've got cancer. Okay. When you're in this scenario, you need an interpreter. So what are the options for navigating language barriers? I'm going to go through 4. Getting by, using your own limited language skills and gestures. Using untrained interpreters, family and untrained staff. Using professional interpreters, or being a bilingual clinician. You will ask me, well, in informed consent conversations, what proportion is doing what? What is happening throughout the country? The answer is, we don't know. We could know, but we don't know. Let me tell you what is happening, what was happening at San Francisco General. San Francisco General is a county hospital for San Francisco. It has probably one of the most renowned interpreter systems, most robust interpreter systems in the country. Like many others, it was created through a lawsuit in the 1980s. And some years ago, Yael Schenker came, who was then a resident, came and said to me, I don't think we're consenting the patients who don't speak English. And I was a young faculty member and said, oh, come on, this is UCSF, what do you mean? But it rang true to me as more of my own patients were coming back saying, and I would say, what did happen to you when you were hospitalized? They put a needle in my chest. Why? I don't know. Well, what did it show? I don't know. So we looked at this, and we looked at Chinese and Spanish patients and compared them to English patients who had received thoracentesis, needle in the chest, lumbar puncture, needle in the spine, or paracentesis, needle in the belly. We found that the same proportion of patients had a documented informed consent discussion in the chart, a procedure note. However, fewer of the LEP patients had a signed consent form in the chart in any language. Only 22% had a consent form in a language that they could read, and a large difference in having fully documented informed consent, which for an LEP patient includes presence of an interpreter. I'm going to fast forward now to a recent study we did just this last year and say that our residents are now more likely to report that they're using interpreters for procedures and consent. However, as you can see, largely often getting by in the red for things like admission histories, updates and check-ins, telling them what the result of a test was, and discharge instructions. And please note, this is UCSF is widely considered one of the very best medical schools and residency programs in the country. What drives underuse? Physician culture, first and foremost. We do what we do. Perception of communication importance. I'm going to sit down and get an interpreter when it's a high-stakes conversation. We know, and of course, time and hassle. I'm just too busy. We know this through our studies. I'm not going to go through them. What increases use of interpreter? Putting in a simple thing like phones at the bedside that are automatically connected to interpreters increase requests by 30%, and then training physicians in interpreter use. That said, physicians may be unaware, but that said, physicians use untrained interpreters all the time. Why is that? Because it's convenient. And also because many physicians are unaware of the evidence on communication errors associated with using family members or untrained staff. Professional interpreters, like the ones we have at the General, are the better alternative. There's substantial evidence for professional interpreters. There have now been many audio tape studies in which professional interpreters have fewer gross communication errors than untrained interpreters. Moreover, patient satisfaction is increased when compared to the use of untrained or no interpreters. Physician satisfaction, clinician satisfaction is increased when professional interpreters are used. Nonetheless, there are issues about professional interpreter that bear underscoring. One, there's a certification supply problem. There are no current mandatory national standards as to what constitutes appropriate certification in professional interpreters. California, for example, mandates interpreter training, but many states do not. The Joint Commission suggests that hospitals have some way of knowing that their interpreters are competent, but doesn't set out clear standards. The quality of interpreters throughout the country is highly variable, and there's limited data on whether or not interpreters are actually used, even when they're available, as in the study I showed you. Let me give you an example in an informed consent conversation. This is a study done at the University of Washington, which is a state that has paid a great deal of attention to informed consent. Here, they audio taped people in the ICU discussions using their own professional certified interpreters. Those audio tapes were then scored by blinded researchers. What they found is that for every exchange of information, for every passage, there was a 55% chance that an alteration would occur. These were additions, omissions, substitutions, and editorialization. 3/4 of these alterations were judged to be of clinical significance, and almost all of them had a negative effect. Let me show you what they found. For example, here, the family member is asking the doctor, what we want to know is that after his lungs get better and when he wakes up, will his brain suffer and affect his ability to recognize people? Interpreter. Okay, so she wants to know about the lungs when he wakes up, so about his lungs, and so what about after, so will it not affect him? The doctor. Yeah, right now it's very interesting to us because we don't understand what the problem is in his lungs, and then goes on to talk about the lungs. Example number 2. Doctor, I don't know. This is a very rapidly progressing cancer. Interpreter. He doesn't know because it started gradually. Interpreters think we need to do a better job. Yale and I surveyed, along with our colleagues, surveyed interpreters on end-of-life discussions. 85% of them had multiple discussions per week. The majority were experienced and were certified. Only half of the interpreters reported that those discussions usually went well. 80% reported wanting additional training in end-of-life interpreting, and 81% felt that the physicians needed more training in working with interpreters. Professional interpreters mitigate but don't eliminate comprehension barriers. In this study done at Bellevue, the researchers were interested in comparing 2 interpreter systems, and they randomized the patients to either one state-of-the-art interpreter system or the other state-of-the-art interpreter system, except when there was a physician available who spoke their language. As people left the ER, they were surveyed by research assistants. Did they understand the MD explanation? What's important to note here are not the differences between the interpreter systems, which are small, but the large difference with the language concordant care, in which 60% said that they did understand the explanation, understand the instructions, thereby showing we have a long way to go with the other 40%. But far fewer of people using professional interpreters, state-of-the-art professional interpreters, understood the prescription instructions. What about other things besides clarity and comprehension? Well, multiple studies have shown less patient satisfaction and less trust. Here's a study we did out of Kaiser of Northern California in patients with diabetes. In terms of patients reporting lack of trust, if you look at this, it looks like the English proficient and the LEP are about 25% report lack of trust in their physician. But when you disaggregate the LEP according to whether or not their doctor spoke Spanish or whether or not their doctor did not with language concordance, you see that 35% report a lack of trust in their physician. Trust is an essential element of any informed consent discussion, as we cannot expect our patients to become physicians and make the choices that we can help them make. Moreover, 20% reported feeling treated poorly because of language, and nearly 40% thought that their physician did not show respect when their doctor did not speak their language. Unfortunately, about 30% of all of our patients, irrespective of language, believe that we do a poor job of listening to them. So what about bilingual physicians? Bilingual physicians are more likely to be patient-centered, more likely to elicit their point of view. And in observational studies, people comparing bilingual physicians and interpreted discussions have fewer open-ended questions and less elicitation of questions or values. In our own work with diabetes, we have found that patients with discordant doctors are twice as likely to have poor glycemic control. However, equally likely to take a cholesterol medication, showing, we think, that as discussions become more complex, the role of language and direct communication takes on more importance. So what should we do then? LEP patients are among the most vulnerable of all patients. Multiple consideration. And above all, this, as I've mentioned, we don't really know what is happening out there. Particularly, I have no clue what is happening in Nebraska, what is happening in Nevada, what is happening in Alabama, in New Orleans, all of these places where there are enormous immigrant populations. How can we improve this? For some things, I think more research is not needed. I believe that we could ask for mandatory use of certified professional interpreters for high-risk treatments and procedures, including high-risk outpatient decisions, such as a decision to start chemotherapy. I think we could set a minimal standard requiring documented use of an interpreter for hospitalized patients as once a day. That once a day, if you're sick enough to talk, if you're sick enough to be in the hospital, you should be able to speak to a treating physician. And obviously, we can improve informed consent for all, incorporating the professional interpreter signature, which would allow us to audit. We can ask for national standards for interpreter competence, and we can facilitate additional interpreter training and training for medical students and residents. We can harness technology. Here, we can use video narratives to standardize conveyance of information and use patient stories to convey options. Why should I have to explain every day which is the options for colon cancer screening if my patients should be able to see me on a video talking through the options once and for all while they're waiting? We could use video-mediated interpretation to improve quality over phone interpreters. And we could certainly have banks of qualified telephone interpreters, i.e. the Australian solution, which makes this available. So back to our hospital. We created new state-of-the-art consent forms in 5 languages and pasted them onto the kits. The forms prompt the physician to call an interpreter. The hospital then repeated the study 1 year later. And many of you, I'm sure, have already anticipated the results, which is that despite our best efforts in scolding and educating the residents, there was no change. Now, many years later, we do show an increase of residents self-reporting interpreter use, but an audit is still pending, all of which shows that physician practice patterns can change, though slowly. In summary, many, if not most patients, have trouble with complex communication. In a study on angioplasty, the most widely done medical procedure done in the United States, among English-speaking white middle-class patients in Western Massachusetts, 80% erroneously believed that the angioplasty would reduce their risk of an MI and reduce mortality. Their physicians, who were also interviewed for the study, did not. I think that improving care for LEP patients and focusing on LEP patients will help improve informed consent for all patients. But in order to do that, we need ongoing commitment from all levels of leadership and from all levels of participation in the medical, in the healthcare industry. And specifically, I think what this group can do is convene a group to focus specifically on the problems of language barriers, and to do it for 2 reasons. One, because it's the right thing to do. People are struggling out there, knowing how to best take care of these patients ethically and legally. But second, if it's not because of these patients, then do it because I think it will improve informed consent for all patients. And thank you for your listening.